Hi, everyone. Welcome to After the Diagnosis, a webinar series presented by the Neuroscience Family Advisory Council here at Boston Children's Hospital. In this webinar series, we'll be talking to caregivers and providers about diagnoses that we face and giving a completely different perspective on them. Today in this episode, we're going to be discussing craniosynostosis. I'm very excited for this episode. We have two different participants, each with a different background. And we're super excited. So let's get started and introduce our participants real quick. My name is Dylan Kirsch. I am the co-chair of NFAC and a current clinical research assistant in the Department of Neurosurgery with Dr. Proctor. And Dr. Proctor, we'll turn to you first. Really briefly, kind of tell me about your path to where you are and how you became interested in the field of craniofacial.
Yeah, so I am by training a pediatric neurosurgeon, and did my pediatric fellowship in neurosurgery here at Boston Children's back nearly 30 years ago now, and joined the faculty after that, and immediately started to focus on craniosynostosis. So it's really been my primary area of clinical focus now for close to 3 decades. And Dr. Meara and I started working together when he arrived, and I'll let him give his background because I don't remember when he started, but
Yes. Well, actually, Dr. Proctor and I have known each other for a long time. So when he was a fellow here, I was a resident in plastic surgery. So that was in the late 90s. And then I left for a while and went to California and Australia, and then came back in 2006. So he and I have been working together now for 20 years, primarily on craniosynostosis cases.
Dr. Proctor, what are craniofacial anomalies? What is craniosynostosis? Why come to Boston Children's for this condition?
Yeah, so maybe I'll start with just some of the basics of what the condition is. And I happen to have a skull here in my hand. So this is not a real skull. Don't worry, it's a model, little label on the back. But if you see here from the front, just to give you orientation, we like to think of our head as this nice hard object, but in babies it starts out as several separate bones, and there's 5 major bones, so 2 in the front, 2 on the sides, and 1 in the back. And if the glare is not getting in the way, what you can see is these little separations between the bones, and then the open soft spot on the top. And the reason that we have these is because our brains are so big as humans that a lot of the growth has to happen after birth. So in the first year of life, the brain grows, and it's almost like a balloon inflating, with the brain being the air and the skull being the balloon. So we push these bones apart, every day, and grow new bone at these little junctions. So the condition that Dr. Meara and I treat quite frequently is called craniosynostosis, where 2 of these bones, or more than 2, fuse together too early, and it both changes the appearance of the baby, but probably more importantly, it doesn't allow for normal brain growth. So if you left it untreated, it could affect brain growth and development. When you ask why come to Children's, I think it's just because we do have a team that's been working together for 20 years, and we have one of the busiest programs in the country, where we average in the range of 90 to 100 cases a year of this condition. And just for reference, only about 1 in every 2,000 babies has it. So doing 100 cases a year is actually a large number.
And Dylan, the thing I'll add is, Mark mentioned the team approach, and I think that's really important. And, it's not just, me and Dr. Proctor, operating on children. It's a whole team of probably 20 different specialists, nursing, psychiatry, psychology, ophthalmology, I could name a lot of different specialties, but it's a huge team. And I think that's what makes it very special here at Boston Children's Hospital, is that once patients come here, they don't have to search out, different specialties. They come here, and we know who they're supposed to see, and at different ages, for example, as we're following them. If they do require an operative intervention, at different ages, they'll see different members of our team depending on who they need to see when. So I think that's really nice for families to know that everyone is here, and everyone's full-time here at Children's, just devoted to the craniofacial program. And I not just on an outpatient basis, but I would also add on an inpatient basis on our floors, and in the OR, we work with a team that does this all the time. So it's really one of the nice things for both of us is that it's part of a team approach for this.
Yeah, and I think, for patients and families, I mean, from what I understand, your patients are on the younger side. So for families that are kind of facing this for the first time, I think there is a measure of comfort that comes with a team of people that are kind of have been trained and work in this and know kind of what to do with your child. So I think for my next question, how is craniosynostosis diagnosed? Is it something that a PCP might see? Is it, kind of sudden? What does that diagnosis look like? And I'll go to Dr. Proctor for this.
Sure. So as I mentioned earlier, most kids will have a change in the way the skull grows as a result of this. And that is something that would be apparent to the family and to the pediatrician. So most of the time, the diagnosis is made based on appearance. And I happen to have a whole wall of plastic skulls here. So just to show you, like, a little hard to see in the background, but like here's again the normal skull I was showing, and here's one where the bone is closed early and the forehead has become very triangular. So when you see that triangular forehead again, with that ridge here, it's a pretty easy diagnosis to make. Now, when you come to see us, we may say, gee, we're 100% certain of the diagnosis just based on the appearance, or we may recommend a CT scan or even an X-ray, sometimes an MRI, depending on what the issues are. But you won't always need to get some sort of radiographic study to make the diagnosis.
Dr. Meara, anything you'd like to add to that?
Well, so what I'll add is when you think about from a patient and family's perspective,
Yeah,
they look at their newborn child and they see a little asymmetry or something that doesn't look right to them. And I would say the first thing they can do is talk to their pediatrician, because pediatricians see a lot of this as well. And most of the time it's not craniosynostosis. Most of the time it's something called positional or deformational plagiocephaly.
sure.
And so that doesn't require surgery. So that's something that, as I said, the primary care folks are pretty good at that, but often then they'll send the patient to us, or sometimes they'll send photographs to me or Dr. Proctor and ask, is this something that you should see? So, we're always a resource both for the pediatricians and other primary care providers to help with that diagnosis, and whether it's something that is really not surgical and then just positional, as I said, or if it's something that we need to take a closer look at.
And Dr. Meara, any symptoms that, babies might present with outside of kind of an abnormal head shape? Is there maybe fussiness, anything that parents, would notice?
Particularly early on, there might not be. So Dr. Proctor showed you that one skull that had the pointed forehead, and it's possible that, the forehead will be a little bit pointed and there won't be any symptoms, because early on there won't. And what we tell parents is, even if one of those sutures is fused, they won't necessarily have any problems or symptoms. So, in fact, the majority of patients won't. So that also leads into why might you need a procedure if you do have craniosynostosis, and part of the reason is or can be just the shape of the skull, but the other reason is the small risk that there could be inadequate volume of the skull for the brain. So you remember Dr. Proctor mentioned how the brain grows very quickly in the first year or so. Well, at 1 or 2 or 3 years, if that suture stays fused, there's a small chance that there won't be enough room for the brain. So it isn't necessarily something that occurs immediately. And I think that's also important for parents to know, that usually this is not something where, within days it has to be taken care of. In fact, sometimes if patients come in early, and I'll let, Dr. Proctor can talk about that later in the session, but there's a minimally invasive procedure that he can do often. But even if that's not indicated, we often don't do the craniofacial surgical procedure until patients are 9, 10, 11, 12 months of age.
You're making my job easy, because my next question for Dr. Proctor was, so let's say child confirmed craniosynostosis. What does the treatment look like? I know we talked about helmet therapy for plagiocephaly, but in terms of a surgical procedure, what does that look like at Boston Children's?
Sure. So as Dr. Meara alluded to, Dylan, it's a little bit dependent on the age of the child. So as I said, very early in life, the brain is growing quickly and then starts to level off. And believe it or not, it starts to level off by 6 or 8 months. So for cases that are diagnosed early, before 3-4 months, we're often considering a minimally invasive called endoscopic procedure, where we make 1 or 2 incisions and just open the fused bones. And each incision's, it's really only about that big, like an inch long. We open the bones, and then we can use a helmet to reshape the skull. So those are the early operations, generally done just by me, not the same team format, because all we're doing is removing bones. We're not reconstructing them. If for any reason that surgery is not done, maybe the window has been missed because it was so subtle that the diagnosis was made later. Number one, I just want to reiterate what Dr. Meara said. The family shouldn't feel like the baby's at risk, because the risks to the brain are really over the first few years, not early in life. It's as the other bones start to close off, sometimes the brain can get restricted. But Dr. Meara and I were then for the older kids past 6 months or so, we'll do what's called an open reconstruction operation. People can hear the name like frontoorbital advancement or cranial vault reconstruction, where we make a bigger incision. It's usually an incision that goes over the top. And in those cases, I still do more or less the same thing. I'm opening the bones, but Dr. Meara is then reconstructing to create a normal shape. And he could tell you more about the reconstruction.
Please.
Yeah, so Dr. Proctor showed that skull earlier on that had that triangular shaped forehead. So I'll just use that as an example. So if he and I, there it is. If he and I operate together, as he alluded to, he will be more involved in removing the frontal bones. And then on the plastic surgery side, my team is involved in changing the shape. So instead of that pointed appearance, changing the shape of the forehead, moving it forward a little bit, and then he and I will put those pieces back together in a slightly different position, just so that the forehead is not pointed, it has a better contour, and so that it's in the right position, and also so that it gives a little extra volume for the brain. So part of the reason to do this is to make sure that the brain has enough volume. So it's partly aesthetic, but also partly structural, in that you want the brain to have enough room.
So for recovery, I guess, so the question is, after, child successfully undergoes the procedure, what does recovery look like for first the endoscopic option and second the open option? And I'll let Dr. Proctor talk about the endoscopic option.
Yeah, so for the endoscopic surgery, the baby is usually in the operating room for a total of about 2 hours. So there's, for those who haven't had your child go through surgery, there's a little bit of time for the setup and the anesthesia. So the surgery itself takes about 30 minutes, but the total time in the operating room is about 2 hours. They'll come out with just a little bandage. Oftentimes for about 6 hours, we'll use a little netting on the head just to keep down some swelling. And the baby is usually a little sleepy from the anesthesia for 3-4 hours. But by the end of that day, they should be more or less back to themselves, eating, starting to smile by nighttime, morning time, and they go home the next morning. So that's sort of the process for the surgery. Now, one thing I'll also add on, because it's not part of the bigger operation, is 2 or 3 days later, they'll then go get fit for a helmet. So that helmet is custom made to help shape the head. So there's definitely more aftercare. The family has to be willing to do the helmet for, on average, 6 or 7 months after surgery.
And then for the other procedure, when Dr. Proctor and I work together on that procedure called the frontoorbital advancement, the reason it's called that is because this is the frontal bone and this is the orbital region, and we're moving both of those, so frontal and orbital. And so that procedure is a little bit longer than the endoscopic procedure. Dr. Proctor and I normally do that on Tuesdays, and we'll go in the room at 7:30. And then, as he was also mentioning, there's anesthesia time. And so we probably get started at 9 or so. And then usually by 12 or 12:30, we're finishing up the case. Then we go to the intensive care unit. So by 1 or 2 or so, or 2:30, we're usually up in the intensive care unit. And we always tell the parents, when you see your child, they'll have a white head wrap on and some gauze and a little drain, one little drain that comes out that just stays for a couple days. And usually that head wrap comes off after a day or two, and the drain usually comes out after 2 to 3 days. And then they usually go home. If the procedure is on Tuesday, they're usually going home by Friday or Saturday. So it's remarkable how quickly they turn around and are feeling back to going home.
It's wonderful. So after discharge, the next question I have.
Can I just add one thing, because this is something families may be interested in. You should know, because we're doing these on small babies, and small babies don't have a lot of blood, there is definitely risk of blood transfusions with both operations. It's a lot lower with the small operation because we're doing so much less. So in that case, it should be 5% or less. With the bigger operations, it's higher. It used to be, quite honestly, 100%. We would just give all the patients blood. We have done a lot to optimize that now. And now I'd say only about 50% of the kids are getting any blood transfusion. But it's important for the family to know that that could be a part of the operation.
Absolutely. And a great point. So back to what I was saying about, after discharge, we talked earlier in the session about the fact that the Craniofacial Clinic has this wonderful team of interdisciplinary folks. So after discharge, during the follow-up period, I was wondering, Dr. Meara, you could start, if you could talk to kind of who gets consulted, who might a family see in the months after the initial surgical treatment?
Well, so let me make a clear separation. There are some patients who just have that one suture involved, and we tend to call that single suture craniosynostosis, or sometimes non-syndromic, which means it doesn't go along with other things. So let's talk about that group first, just for a moment. So in that group, we would every year have them see the ophthalmologist, because believe it or not, the ophthalmologist can look in the eye and look at the back of the retina and look at the optic nerve. And that's almost like a little pressure valve, and it can tell you often if there's extra pressure in the brain. So that's just a way of checking kind of indirectly. So that's just part of the routine follow-up. So we'll have ophthalmology check the kids every year. And then Dr. Proctor and I will see the patients every year. And that's pretty strict, every year or so until they're 5, 6-ish, and because you remember Dr. Proctor was mentioning how fast the brain grows in the early years. So by the time children are 6 years old, their brain has pretty much finished growing. So that's the first 6 years. And I guess the only other thing I'll add is that usually about 2 weeks after that initial operation, I'll just see them back in clinic just to check the wound and make sure that everything looks good. And we use dissolvable sutures, just so parents know, so that we don't have to remove anything. We've tried to adapt the whole procedure so that there's very little to do after. A couple decades ago, we used to put in sutures that had to be removed, or staples that had to be removed, but we're doing everything to make it as easy for the parents and for the children as possible. So that's what the first maybe 6 years looks like for the single suture non-syndromic craniosynostosis.
Okay. And then Dr. Proctor, I know you were talking about for the endoscopic option that the babies will be fit for a helmet. How long is that helmet therapy? What does that kind of process look like, and for how long?
Yeah, so at the helmet therapy, I was just turning to see if I had a helmet, but I'd have to go get it up there. The helmet therapy will usually start within a week of surgery. As I said, and we've done now nearly 900 of these operations, so we have a lot of data. The length of time in the helmet averages between 6 and 7 months. But some kids need to go a little longer, but we stop it in all children by their first birthday.
Okay.
So that would indicate the period of time in the helmet's never more than about 9 or 10 months, depending on when we did the surgery.
And then my last question in terms of follow-up, you guys have been doing this for a while now. Kids that have, single suture craniosynostosis, do they have activity restrictions later on in life? Are they able to go play sports and kind of do their thing? Dr. Proctor, I'll give this one to you.
Yeah, I did. We'd both have the same answer. So the goal is that they have a normal life, but they shouldn't have restrictions and there shouldn't be limitations. And I should say, because of what Dr. Meara, he talked about the non-syndromic, we also deal with patients who have more complex problems where they've got genetic disorders where multiple bones are fused. It could be that their fingers are fused, toes are fused, facial bones are fused. Those children are, the answer would be different for them. They probably will have a fair number of restrictions and be seeing many more specialists over time, like our neuropsychologists, our dental team, our oral maxillofacial team. But for the average child with just single suture synostosis, they're probably going to have a totally normal life.
Great. So 2 more questions. First, what should a parent know and kind of do once a child is diagnosed? I know we were talking a little bit earlier in the day about some patient advocacy groups that you guys might recommend if families are looking for a little bit of extra support. And Dr. Meara, I know we were emailing about this earlier today.
Well, I'd say a couple things. One, as Dr. Proctor said, what I would tell parents is, don't panic, don't worry. This is not something that needs to be taken care of by, Tuesday at 9 a.m. So
Right.
There's time. That's why we're here. We're here as a resource to them and to the primary care and the pediatrics doctors. There are some resources, and I think, can we put those in the
Sure can.
in the chat? Okay,
Yeah.
so I think there are some great resources, different patient and family groups that can help with support. Our team is also here for support. So we have, nursing, social work, psychology, et cetera. So we also can provide support. So we just want the families to know that we can provide whatever support is needed, and we're here, for them 24/7.
And to Dr. Proctor, the same question. If you were to tell a parent or a patient one thing about craniosynostosis, what would it be?
Yeah, well, just reiterate what I said before. Most kids with single suture synostosis should go on to live pretty normal lives, but likely will benefit from surgery over just watching with conservative therapy. And the other thing I want to say, partly to the question you asked Dr. Meara, that if the family receives this diagnosis, especially since many of our operations are time sensitive, we're going to see you pretty quickly. So don't worry that it's like, going to take 3 or 4 months to get an appointment. I just literally just before this webinar started, I received a call about a patient who was just diagnosed today. We're going to see him over the next couple of days. And based on the patient's age, I've already spoken to the family by telephone to plan surgery for about 10 days from now. So we know it's very stressful for the family. The operations are also time sensitive. So we generally are very accommodating in getting them in quickly.
Dylan, I'm glad that Dr. Proctor mentioned that, because it's interesting, because on one hand, we don't want parents to be nervous that something bad is going to happen in a week.
Right.
It's absolutely true. If you can get in before that, 4-ish, 5-month time, then that oftentimes Dr. Proctor can do that endoscopic procedure. So that's, definitely something that would be beneficial. So that's why, it's good to reach out to us right away. Don't feel badly about saying, hey, is this something that we should have looked at?
I do have one more question, and this is coming from my own interest, but I'm very curious to hear from both of you, kind of what the latest and greatest research that we might be working on here in terms of craniosynostosis. There's a couple different projects going on just from hearing from our other research assistants, but would love to hear what you guys are up to in terms of kind of pushing the knowledge on craniosynostosis.
Well, I can say a couple things about that, and then Dr. Proctor can add to that. One of the interesting things that's come up recently is the hospital has been very supportive and is helping us financially do what's called whole genome sequencing on all of the children. And so that's looking at their entire genome. And the reason that that's potentially interesting is that in a number of the patients, we have already found new genetic mutations that weren't associated with craniosynostosis before. And so now we have a team, and we've already done this in one case where we've taken that gene and put it in a mouse model and what's called a zebrafish, which is a very tiny little fish that you can do genetic studies on. And the reason that's important is we can then look at what does that gene actually do. So you can do specific studies to look at what is the mechanism, what is that mutation causing, why is it causing craniosynostosis. So it's an example of where, people talk about bench to bedside research, where we're going right from a patient to the bench, trying to find out why does this happen, and then hopefully we'll find a solution that we can take back to the bed, so to speak. So I think that's really exciting to be able to do things almost in real time, where you're looking at genetic mutations, investigating them in the lab, figuring out, okay, what's the mechanism, and then being able to take that back to a patient. That's incredible.
Absolutely.
Yeah, and I'll add one additional thing, but just to reiterate that point, like right next to Dr. Meara's shoulder, there's a skull, and that's ties in a couple of things I was going to say. So number one, that's a patient. I mean, we work so closely together. I know our patients so well that I know who that is, and I will say that's a patient for whom we discovered a new gene that caused that condition. But the other thing to say, like what I showed you previously, these were just standardized models that were made based on generic patients. Now we're in the era where we can make 3D models just like that, plan the whole surgery out on a computer before, print models, practice the operation if it's really unique. So the whole era of virtual surgical planning and practicing the operation and knowing exactly what we're going to do before we get into the operating room is upon us. And that's why Dr. Meara has those models there. Those are both patients that we have treated, but first we treated on a model before we treated on the actual babies, and it saves a lot of time in the operating room. And it's not like we have things to do. It's like we don't want the baby under anesthesia for extra hours as we try and figure it out.
No, it's fantastic, and getting to work and to shadow, it's so clear that it's such an amazing program. I know all these families are so grateful for both of you and the entire team. Thank you guys both for such a fantastic conversation. As Dr. Meara mentioned, we'll be linking below 2 links to some external support. And you can always come to us at the Neuroscience Family Advisory Council, which will also be linked below for more information on us. Please be sure to head to our website for more resources and information, and stay tuned as we announce even more after the diagnosis episodes on more neuroscience topics. Thanks again, guys. This was fantastic.